Going forward on the oxytocics, the next group of drug in oxytocics is prostaglandins. Prostaglandins are a group of lipids made at sites of tissue damage or infections that are involved in dealing with injury and illness. They control processes such as inflammation, blood flow, the formation of blood clots, and are utilized for induction of labor in pregnancy. The source of prostaglandins, mainly arachidonic acid. The mechanism of action of various prostaglandins are PGF2 alpha promotes myometrial contractility, PGE2 helps in cervical maturation, and PGE1, a potent vasodilator agent, increases peripheral blood flow, inhibits platelet aggregation, and induces bronchodilation. It significantly increases myometrial contractions, decreases both total collagen content and the area covered by connective tissue. The use of prostaglandins in obstetrics. They are used in induction of abortion and missed abortion. They are also used in termination of molar pregnancy, induction of labor, and cervical ripening prior to induction of abortion or labor, augmentation of labor, management of atonic postpartum hemorrhage, and in the medical management of tubal ectopic pregnancy. The advantages of prostaglandins are it has got a powerful oxytocic effect irrespective of period of pregnancy. As such, it can be used independently, especially in the induction of abortion with success. In later months, it can be used for acceleration of labor and has got no antidiuretic effect as opposed to oxytocin. The drawbacks of prostaglandins are that it is costly, but not all the preparations are costly. Then there are certain unpleasant side effects on systemic use such as nausea, vomiting, diarrhea, pyrexia, bronchospasm with PGF2 alpha, and abdominal pain. When used as abortifacient, it can cause extensive lacerations in the genital tract. And uterine tachysystole is one of the drawbacks of prostaglandins in general and misoprostol in particular. Uterine tachysystole means there are more than 5 contractions in 10 minutes. The contraindications to prostaglandins include mechanical obstruction of delivery, fetal distress, and conditions which predispose to uterine rupture. And one should exercise precautions in conditions like asthma, multiple pregnancy, glaucoma, and uterine rupture. So, PG analogues include PGE1, that is methyl ester of PGE1 is misoprostol, which is commonly used. Then PGE2 is dinoprostone. This is less toxic and more effective and so widely used. Then PGF2 alpha, that is dinoprostone tromethamine, and PGF2 alpha methyl analog is carboprost, which is commonly used. Contraindication include hypersensitivity to the compound and uterine scar like previous cesarean or myomectomy scar. Preparations can be in the form of tablet, vaginal suppository, vaginal pessary, then Prostaglandin E2, and then parenteral preparations are also available. The differences between prostaglandins and oxytocin. The prostaglandins contract uterine smooth muscles not only at term as with oxytocin but throughout pregnancy. They soften the cervix whereas oxytocin doesn't do that, and prostaglandins have longer duration of action than oxytocin. Now coming to individual preparations, methyl ester of prostaglandin E1, that is misoprostol. Both vaginal and oral misoprostol are used for either cervical ripening or labor induction. Then vaginal misoprostol followed by oxytocin if needed compared with oxytocin alone results in fewer failures within 24 hours. Then prostaglandin use leads to a higher incidence of uterine tachysystole, but cesarean delivery rates are similar both in the misoprostol group as well as in the oxytocin group. The advantages of misoprostol include ease of administration because it can be used orally, vaginally, rectally, and even buccally. Then cost effectiveness is quite cheap as compared to oxytocin, and it's easy storage. It doesn't need any special storage, it can be stored anywhere, whereas the oxytocin has to be stored at the temperature of 2 to 8 degrees centigrade in the refrigerator. So that's a big advantage in case of misoprostol. The misoprostol binds to biomaterial cells, causing strong uterine contractions leading to expulsion of the contents. It also causes cervical ripening, softening, and dilatation of cervix. It is extensively absorbed and gets deesterified to its free acid, and half-life of misoprostol is 20 to 30 minutes. Usually 100 microgram of oral or 25 microgram of vaginal misoprostol are similar in efficacy compared to this intravenous oxytocin for labor induction at or near term. Induction with prostaglandin E1 may prove ineffective and require subsequent induction or augmentation with oxytocin. Studies have shown that either, that is misoprostol or oxytocin, is suitable for labor induction. So both misoprostol and oxytocin are suitable for labor induction in women at or near term, either with PROM or with favorable cervix. So monitoring. Patient on misoprostol should be carefully monitored for any side effects like diarrhea and fever which may require medication. And the risk of rupture is almost more than oxytocin since it causes very strong uterine contraction. Besides the use in induction or augmentation of labor, that's also used as a drug along with the mifepristone in cases of medical termination of pregnancy. The government uses that mifepristone 200 mg and misoprostol 800 mg tablets. 200 microgram tablets each of misoprostol is usually given. On day 1, mifepristone 200 mg is given, and after 24 to 48 hours, it is misoprostol which is given, either 400 microgram or 800 microgram. And the various routes utilized are oral, vaginal, or buccal route can be utilized for this. So this shows the recommended regimens, that is FIGO recommended regimens of 2017 of use of misoprostol alone. It can be used in early gestation and mid-trimester and in the third trimester. So this is a very exhaustive chart, but some of the important points in this I would like to mention. Like in pregnancy termination, it can be used as 800 microgram sublingually every 3 hours. And in incomplete abortion, it can be used as 600 microgram orally or 400 microgram sublingually. And cervical preparations for surgical abortions, like if you want to do MTP or bisection evacuation, then 400 microgram sublingually can be given 1 hour before the procedure or per vaginally 3 hours before the procedure. In case of second trimester, mid-trimester abortion, it can be used as 400 microgram per vaginally, sublingually or buccally every 3 hours at 13 to 24 weeks gestation. And in case of prevention of postpartum hemorrhage, it can be used as 600 micrograms orally. And PPH secondary prevention, it can be used as 800 micrograms sublingually, and the same dose is used as in PPH treatment also. So there are several uses of misoprostol, and one can follow this chart as required. So coming to prostaglandin E2, it is widely used as it is less toxic and more effective than PGF2 alpha. It is quite costly, and preparations used are vaginal tablet, which contains 3 mg of prostin E2. Then this is put in the posterior fornix, followed by 3 mg after 6 to 8 hours. Maximum dose used is 6 mg. Then the vaginal pessary with retrieval device it also can be used in these cases. Then the prostin E2 dinoprostol gel, available as Ceviprime in our country. It's a 500 microgram dose and it comes in the syringe as shown over here. Then the piston is removed and put inside this barrel, and this is where the Ceviprime or the prostaglandin E2 will be there, and it is inserted into the cervical canal, and just below the internal os it has to be injected. So this is usually used for cervical ripening before the proper induction of labor. So when the Bishop score is less, then this drug is used for ripening. Then parenteral preparations are available, that is PGE2 intravenous preparation as 1 mg per ml. Then PGF2 alpha is another preparation which is used in obstetrics. It is a prostin available in form of prostin F2 alpha, that is dinoprost-tromethamine, that is 5 mg per ml, or methyl analog of PGF2 alpha, which is carboprost. It comes as 250 microgram per ml. So mechanism of action is carboprost is a synthetic prostaglandin, binds the prostaglandin E2 receptors, causing myometrial contractions, causing the induction of labor or the expulsion of the placenta. This is used in case of treatment of atonic PPH, when all the measures like oxytocin, methergine, misoprostol have failed. Then this can be used as 125 or 250 microgram per ml. 1 ml usually used at a time, and the route of administration is intramuscular, not intravenous, or it can be used directly intrauterine. Also injection can be used, especially when we are doing cesarean and the atonic PPH occurs. Intrauterine route can also be utilized by injection methergine also. So if you see the various procedures step by step, if you are going in atonic PPH, this drug comes after we have used oxytocin, misoprostol and methergine. And coming to a next group of oxytocics is ergot derivatives. This is a natural alkaloid of Claviceps purpurea that grows on various grains like rye and wheat. And they are derivatives of the tetracyclic compound 6-methyl-ergoline. Therapeutically useful natural alkaloids are amide derivatives of D-lysergic acid, and semisynthetic derivatives are obtained from catalytic hydrogenation of the natural alkaloids, for example, methergine, or also called as methyl ergonovine. Ergot alkaloids are detoxified in the liver and eliminated in the urine. Mode of action: they act directly on the myometrium, inducing tetanic contraction without relaxation in between. So it causes contraction of the uterus as a whole, that is fundus and the cervix, both are contracting. So it tends to compress rather than to expel the fetus, as this thing opposed to oxytocin and other prostaglandin preparation. This effectiveness is highly effective in as far as the hemostasis is concerned, and indications include therapeutic to stop the atonic uterine bleeding following delivery, abortion or expulsion of hydatidiform mole, and it's prophylactic against postpartum hemorrhage following delivery, and also is a component of active management of third stage of labor, can be used instead of oxytocin. Then effect on other system include like vascular effect. Direct peripheral vasoconstriction in large doses causes damage to the capillary endothelium. example ergotamine and dehydroergotamine. Then on the gastrointestinal effect, increases peristaltic activity and can potentiate the action of neostigmine on the gut. Among the miscellaneous effects, they include their partial 5-hydroxytryptamine agonist on certain blood vessels and selective antagonist on various smooth muscles. They are absorbed orally from the gastrointestinal tract, usually given intramuscularly, but can also be taken orally or rarely can be used intravenously also. And during cesareans, sometimes we give it intrauterine also if the patient doesn't respond with other routes of administration. And like I said before, this is extensively metabolized in liver and excreted through the urine, and 90% of metabolites are also excreted in bile. The contraindications include pregnancy, first and second stage of labor, suspected pleural pregnancy, should not be given at just after the delivery of the first twin, so one should be careful in those cases. Then cardiac diseases, vascular diseases, severe preeclampsia and eclampsia, and if there is a hepatic and renal impairment is there in Rh negative mother, and contraindicated also in vascular diseases like Raynaud's and in atherosclerosis. Then therapeutic contraindication include heart disease or severe hypertensive disorder. And ergot alkaloids, they reduce milk secretion, and if it is used for a prolonged time, and this is also excreted in milk. So preparations available: ergometrin as 0.25 mg or 0.5 mg ampoules or 0.5 mg tablets, methergine as 0.2 mg ampule or 0.2 mg tablet also. 0.5 to 1 mg is wrong. Then symptometrin is another preparation which we mentioned in oxytocin also. It includes 0.5 mg of ergometrin plus 5 units of symptometrin. So it's a synergistic action of both in this preparation. Then onset of action of the ergot alkaloids. Ergometrin, it goes a shorter, if intravenously, shorter action. It is 45 to 60 seconds, whereas methergine takes 5 minutes. And IM is 6 to 7 minutes ergometrin and 7 minutes methergine. Oral, both are like 10 minutes onset of action. So there is a delayed onset of action in oral route. Therapeutic uses, mainly it is used for prevention as well as treatment of postpartum hemorrhage. And the uterus at term is extremely sensitive to the stimulant action of ergot. Therefore, ergot derivatives should be used only for control of late uterine bleeding. Should never be used before delivery. And moderate doses produce a prolonged and powerful spasm of the muscle, quite unlike the natural labor. Then oxytocin is the preferred agent for control of postpartum hemorrhage, but if this is ineffective, ergometrin 0.2 mg is given intramuscularly. And it's usually effective within 1 to 5 minutes and is less toxic than other ergot derivatives for this application. That's why practically methergine is being used in obstetrics. So common side effects include nausea, vomiting, diarrhea, headache, confusion, depression, and drowsiness. The side effects are more with the IV use, especially the vomiting part. Then there can be precipitate rise of blood pressure, myocardial infarction, stroke, and bronchospasm because of the vasoconstrictive effect of methergine. Prolonged use may result in gangrene formation of the toes and fingers because there is a peripheral vascular insufficiency due to intense vasospasm. Then it can cause hourglass contraction of the uterus. So then the placenta gets retained inside the uterine cavity, and then there is a placental retention of retained placenta occurs, and sometimes one may have to do manual removal of the placenta. Then the prolonged use in puerperium may interfere with lactation. What are the differences between oxytocin and ergometrin? This contractions, ergometrin causes tetanic contraction and doesn't resemble a normal physiological contraction, whereas oxytocin resembles normal physiological contraction. So there is a law of polarity is maintained, and whenever the oxytocin is given, so that is the fundus contracts followed by the lower part of the uterus. So uses ergometrin can be used only in postpartum hemorrhage with the prevention or treatment, and this has got various multiple uses. Besides being used for postpartum hemorrhage, it can be used for induction and augmentation of labor. Then the onset is moderate onset in ergometrin, long duration of action, whereas in oxytocin it's a rapid onset and as well as shorter duration of action. Then the hazards of ergot alkaloids include nausea, vomiting, sudden rise in blood pressure, stroke, and rarely gangrene of the toe. And oxytocin, it is mainly uterine hyperstimulation, antidiuretic effect, and sometimes uterine rupture can occur, inguinal pain, and rarely hypertension. So here we finish the oxytocics and then proceed to antihypertensives. So antihypertensive in pregnancy are usually used as a part of crisis management until the appropriate treatment of the condition, that is the prompt delivery of the patient, can be arranged. So routine use of antihypertensive drugs is usually not favored, and they used in chronic hypertension and prevent preeclampsia. So purpose of instantly bringing down the blood pressure in case of chronic hypertension, in case of eclampsia, preeclampsia, and sometimes in hypertension, is to prevent cerebral hemorrhage, to prevent abruption of the placenta, to prevent eclamptic fit, to cover the stress of labor, and to cover the stress of general anesthesia if that is contemplated. Since safe maturity of the fetus is also in concern in case of chronic hypertension, preeclampsia, and eclampsia, but that is of a secondary one. The main purpose is this. So category of antihypertensives according to FDA which are being used in pregnancy can be category B, C, and D. So mainly the category B drugs are used in pregnancy for the antihypertensive part. So antihypertensives are essential when the blood pressure is more than 160 by 110 millimeters of mercury or higher, usually to protect mother, and the condition which were enumerated in the last slide. So aim here is to reduce the blood pressure to a mean of less than 125 millimeters of mercury. That is the mean arterial pressure, which is systolic blood pressure plus twice the diastolic blood pressure divided by 3. So that should be less than to a mean of less than 125 millimeters of mercury. So the benefits of antihypertensives in mild to moderate hypertension as yet is not yet known. So if there is any risk of target organ damage, antihypertensives are given to maintain systolic blood pressure of equal to or less than 140 millimeters of mercury, and diastolic blood pressure should be between 90 and 100 millimeters of mercury, and less than that usually one should not use because it would reduce the placental perfusion and can cause fetal distress. So one should not be over enthusiastic in administering the antihypertensives. So this antihypertensive is usually used to tide over the period. Ultimately, patient has to deliver, then only that hypertension will reduce. So most of the antihypertensives are transported actively by intestinal amino acid carrier, and less than 1/3 of an oral dose is usually absorbed, and it is partly excreted unchanged in urine. An antihypertensive effect develops over 4 to 6 hours and lasts for 12 to 24 hours in most of the oral antihypertensive drugs. So various groups of antihypertensives used can be divided as sympatholytics, that is methyl dopa and rozapine. Then the adrenergic receptor blocking agents. Examples are labetalol, propranolol, atenolol. Then the vasodilators like hydralazine, nitroglycerin, and sodium nitroprusside can be used. Calcium channel blockers like nifedipine or nicardipine can be used. And ACE inhibitors, examples being captopril, lisinopril. However, these are avoided, these and the ARBs, that angiotensin receptor blockers, are avoided in pregnancy because they are category D drugs. And ACE inhibitors, they cause oligohydramnios, renal impairments, and limb contractures, and prevents the normal lung function in the fetus. So now coming to the drugs which are usually used in pregnancy, they are the category B drugs. So category B drugs are those which have a potential benefit, in which the potential benefit outweighs the potential risk to the fetus. So in this category, the animal reproduction studies have not demonstrated a fetal risk, but there are no controlled studies in pregnant women. So they are comparatively safe to be used in pregnancy. So among these, there are the adrenergic receptor blocking agents and vasodilators are there, like adrenergic receptor blocking agents like labetalol and propranolol, and the vasodilators like hydralazine, nitroglycerin, and sodium nitroprusside. So coming to the individual antihypertensives, the methyl dopa, which is a central and peripheral anti-adrenergic action. This results in the reduction of the arterial pressure, and it is effective and safe for both mother and fetus. It used to be drug of first choice few years back, but nowadays it is not available also. Usually this thing. And the contraindications include hepatic disorders, psychiatric patients, and congestive cardiac failure. Dose started orally as 250 milligram twice a day or thrice a day, may be increased to by again 250 milligram every 2 to 3 days to reach to up to 1 gram 4 times a day, depending upon the response. The IV infusion is usually at the dose of 250 to 500 milligrams. Side effects, maternal side effects include postural hypotension, hemolytic anemia, sodium retention, excessive sedation can be there because of this drug. Then the Coombs test may become positive, and one should have exercise precaution in case of hepatic disorders, psychiatric patients, congestive cardiac failure, and there is postpartum risk of depression also with this drug. And the fetal side effect includes intestinal ileus. Coming to the next group of drugs, that the adrenergic receptor blocking agent, the labetalol is the example. The mechanism of action of labetalol is it has got a combined alpha as well as beta adrenergic receptor blocking action. The contraindications for this drug include hepatic disorders, asthma, heart block, and congestive heart failure. Orally, it is started as 100 milligram twice a day or maybe thrice a day, may be increased by 100 milligram BD every 2 to 3 days, maximum dose being 2400 milligram daily. Then the IV, usually given in hypertensive crisis, 20 milligram IV stat over 2 minutes. Then after 10 minutes, one can take the blood pressure and give the next dose after 20 minutes, usually 40 milligram. Then another, if the patient doesn't respond in 20 minutes, then 80 milligram is given, and another 80 milligram is given till BP is controlled. Maximum dosage here being 220 milligram. Labetalol can also be given by IV infusion, as 1 to 2 milligram per minute until the desired effect is reached. Side effects are less compared to the methyl dopa, and efficacy and safety with short-term use appears equal to that of the methyl dopa. Another adrenergic receptor blocking agent is propranolol, mechanism of action being a beta adrenergic receptor blocker, whereas labetalol was both alpha and beta adrenergic receptor blocker. Contraindications of propranolol are bronchial asthma, renal insufficiency, diabetes, cardiac failure, and the drug is better avoided for long-term therapy during pregnancy. For long-term therapy, labetalol is better. And dose is orally 80 to 120 milligram in divided doses. Side effects include severe hypertension, sodium retention, bradycardia, bronchospasm, congestive cardiac failure, and hypoglycemia. Fetal side effects include bradycardia and impaired fetal response to hypoxia, IUGR when it is started and during first or second trimester. Then the neonatal side effect is in form of hypoglycemia. Prazosin is another drug which can be used, the mechanism of action being selective postsynaptic blocker. It decreases plasma renin activity and reduces cardiac preload and afterload. Contraindication is hypertension and syncope. To avoid this, one has to start with a very low dose and gradually it has to be increased. The dose orally is 1 milligram twice a day, may be increased up to 20 milligram per day. Side effects include hypertension, nasal congestion, and fluid retention. Hydralazine is an arteriolar vasodilator. It relaxes the arteriolar smooth muscle. Contraindications: because of the variable sodium retention, diuretics should be used whenever hydralazine is used. Orally, it is a weak drug and should be combined with methyl dopa or beta blockers. The oral dose is 100 milligram per day and 4 divided doses. Intravenously, 5 to 10 milligram intravenous or intramuscular initially can be given, and then 5 to 10 milligram every 20 to 30 minutes, or one can use 0.5 to 10 milligram per hour IV infusion. Side effects: maternal include hypertension, tachycardia, arrhythmia, palpitation, and lupus-like syndrome. In fetal, it is reasonably safe. However, neonatal, it can cause thrombocytopenia. Nifedipine is also one of the commonly used drugs. It has got a direct arterial vasodilation effect and also it's a calcium channel blocker. The usual dose is oral dose 5 to 10 milligram twice or thrice a day and should not be used sublingually because there is a risk of precipitous fall of blood pressure. And dose has to be titrated as per the blood pressure response. The contraindication: simultaneous use of magnesium sulfate, which is used as anticonvulsant in case of eclampsia and to prevent convulsions. And as it's also used as tocolytic drug, and this could be hazardous due to the synergistic effect of nifedipine and magnesium sulfate. Both are dealing with the calcium channels. The side effect of nifedipine is flushing, hypertension, headache, tachycardia, and inhibition of labor. So nifedipine is used as also sometimes used as tocolytic agent. Sodium nitroprusside is another drug which acts both arterial and venous direct vasodilator. So this acts by activating smooth muscle cell receptor. It's a drug of last resort for acute hypertension. And IV infusion is usually given as 0.25 to 8 microgram per kilogram per minute. The maternal side effects include nausea, vomiting, and severe hypertension. And fetal toxicity is because of the metabolites which are produced, that is cyanide and thiocyanate. Fetal toxicity includes oligohydramnios, intrauterine growth retardation, fetal and neonatal renal failure. Nitroglycerin, it acts by relaxing mainly venous and also to some extent arterial smooth muscle, given as IV infusion 5 micrograms per minute to be increased every 3 to 5 minutes, can go up to 100 micrograms per minute. Side effects include tachycardia, headache, methemoglobinemia. So diuretics usually not antihypertensive, but sometimes it has to be used along with other hypertensives in case of pregnancy. It can be used the following conditions like pregnancy-induced hypertension with massive edema, if there is associated pulmonary edema, if severe PIH or eclampsia cases, in case of severe anemia in pregnancy with heart failure, and prior to blood transfusion in case of severe anemia, and as an adjunct to certain antihypertensive drugs such as hydralazine or dioxide. The common preparation use furosemide, thiazide, and rarely spironolactone. The dose of furosemide, which is a loop diuretic, is 40 mg daily. In acute conditions, parenterally it can be given as 40 to 120 mg. It directly prevents reabsorption of sodium and potassium from loop of Henle. Maternal hazards include weakness, fatigue, muscle cramps, hypokalemia, hyponatremia, hypochloremic alkalosis, and postural hypertension. There's diminished placental perfusion in fetus leading to fetal compromise. Thrombocytopenia and hyponatremia can occur. The hydrochlorothiazide, it acts on the distal tubule by increasing excretion of water, sodium, chloride, and potassium, and is used in edema with hypertension. Oral dose 25 to 100 mg per day. Side effects include polyuria, glycosuria, urinary frequency, nausea, vomiting, anorexia, urticarial rash, fever, increased creatinine, and decreased electrolytes. So, choice of antihypertensives in pregnancy. The first line drugs are usually labetalol, followed by nifedipine and then hydralazine. So, if these don't work, then the second line of drugs may be used like nitroglycerin and sodium nitroprusside. Like I said earlier, methyl-dopamine used to be the first line drug earlier, but nowadays I have not seen it this thing recently. So to summarize to some antihypertensives like methyl-dopamine central peripheral antinergic action with dosage being 250 to 500 mg thrice or 4 times a day. Labetalol, both alpha and beta adrenergic receptor blocker, 100 mg twice, thrice, or sometimes 4 times a day depending upon the response. Then the nifedipine calcium channel blocker, 10 to 20 to 30 mg also can be used. Hydralazine is a vascular smooth muscle relaxant, 10 to 20 mg twice a day. Thank you.